quite readily available, and the team from KCCA is quickly available once you signal the system. So therefore, what is IPC? That's the main discussion for us today. So what I've done was just to preview Ebola, and then now we come to our main reason for discussion. So I don't know whether you want me to stop and you ask the question, or I can go through. I feel like I should go through, then we can write down the question and then ask them at the end of the day. So one would wonder, so IPC, what is it? How important is it? So here is the critical role of IPC. It helps us as the healthcare workers to protect ourselves. There is what they call the standard precautions, and then there is what we call one that has been tailored to a particular infection. If it is for Ebola in this case, so we tailor our IPC for Ebola. So transmission-based precautions. So those two are very important in protecting us and see that we work without getting infection. And the same thing applies to our communities. We don't want communities to get more of these infections. So the different interventions of IPC is able to protect also the community, and the same as the patient. So here we're seeing a healthcare worker, a key resource in the healthcare system, because we want the system to be running. Your service that you're offering should continue, and that's the role of the response, to see that what was going on before the outbreak continues. And when we do that, we achieve our goal. Other than having the system shut down because Ebola has overrun the healthcare systems, staffs are infected, and that becomes a problem. So therefore, staff safety is critical for ensuring that services continue. And therefore, when we are talking of IPC, what do we mean in that case? We define it here as an evidence-based practice and procedures which, when consistently, that's the key word, consistently applied in a healthcare situation, it can be able to prevent transmissions, for Ebola in this case, and reduce the risk of transmission of Ebola in this case to the healthcare workers, to the patients, to the visitors, and those who actually visit the hospital. So for us to do that, therefore, we need to break the chain of transmission. And we know that the chain of transmission, we have looked previously, saying that, for example, for Ebola, we have the host population of the fruit bats, and that can come up and get release the infectious agent, that is Ebola virus, and this virus can now get into the human population through a spillover events from the animal to the first human being, giving an index case, and then subsequently that interaction between will of course be through the port of entry, and there will be a means of transmission of the virus, and then when that person is now infected, finally he will continue to infect others by releasing the virus through the port of exits, which in this case can be the bleeding that is coming up from the openings of the body. It can be sweat that is coming out from the sweat pores, vomiters. So all these are now exits of the virus, and so the different interventions, therefore, that we'll be discussing is actually summarized in this chain of infections picture, where you can see different interventions. Education, you need a policy that is going to guard and inform the communities about spillover events. You need environmental management, sanitation, disinfection, and early diagnosis once a case has been identified. And so that is through screening at the different points of care. That's why we are discussing this. And treatment of underlying disease and immunization. We know that immunization in regards to Ebola, we have the Zaire species having a good, potent vaccine, which if an outbreak of a Zaire species occurs, we can be able to do a ring immunization or ring vaccination to protect the people who are at great risk, including the healthcare workers. And of course, to cut off the entry through the port of entry, we have listed quite a lot of actions, including the personal hygiene and hand washing. And those are the critical things. That's why we are discussing today. And as the same as isolation of the cases, once you phone a case and you've identified, you need to isolate. So the confirmed case, again, is isolated different from the one who is just a suspect, and then there are those who are contacts. So those are different three categories. Some contacts are not having symptoms. So again, we can be able to quarantine and isolate them respectively. And disinfection of the places where we are found a case. In this case, we are doing ring IPC, where any case that has been confirmed, we do a ring IPC, and the ring IPC includes disinfecting the key structures in that place of about 1/2 kilometer. So if a case has been found around in your facility, we make a ring of 1/2 kilometer and ensure that other facilities in that within that 1/2 kilometer radius is effectively disinfected. Training has been done, isolation capacity has been ensured, and hand washing is functionalized. So it's the same thing across the chain. So those are the key things. And the IPC therefore has a hierarchy, which we prefer to start with the elimination, where you find for any of the situation that you'll be dealing with, you rather have zero chance of an infection occurring. So therefore, in that case, you physically remove the hazard so that you eliminate any chance. For example, I'll talk about the Mulago ETU, where options for management of waste was discussed. One of them was to see that we do an on-site incineration of the waste to eliminate any chance of an outbreak going out of Mulago. But also because of the control of way of burning, waste burning in the city, it was not possible. So we went into another option where now we are transporting this waste using an accredited company to go and incinerate it off-site, very far away. But of course, my point here is that elimination is to remove any possibility of a chance of the hazard making an impact. So that's the prime that you want to see. You want to eliminate any chance of infection or getting from one person to another. And substitution, engineering controls, administrative controls, and PPE. So these are is like an inverted cone with the different preference. So for example, engineering controls here, we are talking about creating a barrier. If you are constructing an isolation equipment facility like the one for Mulago and the one in Entebbe, you're going to make considerations to see that your walls act as barriers between different categories of patients. The contacts who are just without symptoms, ones who are having symptoms, and the ones who are confirmed. So these engineering controls are part of those key IPC hierarchy. As the same as in the waste management, where initially you may find that the waste management pit can be accessible to animals, and then you want to do some engineering control to make sure you control the access by animals by putting in a chain link, and you make sure all animals cannot access this waste in where the waste site where you put your Ebola waste. So all these are engineering controls. The same with administrative controls, where here the management of the facility, and that's why we are meeting you today. The management of the facilities have to make changes on improving IPC. You appoint an IPC person, focal person, you train the person so that they can be able to mentor others on IPC and make changes to make sure that there is an improvement in infection and prevention practices in your facility. So, and then of course, at the end of the day, when all that is done, you'll be left with a number of cases where you need to protect yourself because you have to manage the situation. You have a patient, for example, and then the patient has to be managed. And therefore, in that case, you now make a proper risk assessment and choose the right PPE and then go to intervene, knowing that there's a barrier between you and the patient. So that's one of our, at the tip of the inverted cone. And in doing so, there are principles for IPC. We are saying that we need to screen all the people who are coming into our facilities, your facilities in this case, so that and when we say screening, we're not just using a temperature gun and then someone goes in, and we are not selecting some people coming in, others are coming with their cars and then they are passing. Even the ones in the car might actually be the one being brought because now they can't walk, they are bringing them with a car. So ideally, everyone is screened, and screening in this case means using the standard tool for screening that has been identified, and that is the screening algorithm. So in that case, when you identify a case that meets the case definition, the recognition is made, and then you have to signal the KCCA through a toll-free call, and then management of the different sources are done. Source control in this case, therefore, means that this case you have identified, we can get their contacts and the contacts of their contacts so that we can be able to manage them effectively and make sure there is no secondary transmission occurring up from this case that has been identified. So even the suspects cases, we need to eventually trace their contacts, and then so that when the results come in, we know that these cases, they had contacts, and here are the list of contacts. So the other thing is that the key principle is the application of standard precautions for all patients. So we are saying here, standard application is that minimum in your facility that stays even when the outbreak is there or the outbreak is not there. So you have to apply standard precautions all the time, and this includes a list of interventions, majorly and mainly, of course, the hand hygiene and use of PPEs and which is down there, and of course the management of waste. So there are standard precautions that should be done for managing, for example, surfaces where you're going to work. So all that you need to, and we have designed a job aid so that you can be able to appropriately identify the job aid for applying your standard precautions for every moment. So the job aids are available actually. And then the implementation of transmission-based precautions. So as opposed to the standard precaution that is there at all the time, and that's the bare minimum for your IPC, we can now review and design a case-by-case transmission-based precautions. So for Ebola in this case, we design Ebola transmission-based precaution, knowing the mechanism of the spread of Ebola, and then that has to be popularized. And that's why we are discussing this, looking through the mechanism of transmission and how we can therefore control infection. And of course, at the last is when all that is applied, choice of PPE appropriately following a risk assessment is done. So I don't know if we're going very slowly. Can someone give me a feedback? Are we going fast? So just to highlight the standard precautions, we have to manage our space, including the floors, the walls of your facility, making sure that you use the job aid to actually make sure your surfaces are clean. And the same with the hand hygiene and the respiratory hygiene. appropriate PPE following your risk assessment being used, safe waste management, waste segregation and management after, injection safety practices, and including the management of sharps, and linen, management of linen and the environment, and your sterilization of equipment. So this is what has to continue without the outbreak of Ebola and with the outbreak of Ebola. So it's something that should be remaining constant and assessed all the time to see that actually the practices are going on. And just to pick up the hygiene, we talked about the 5 moments of hygiene, and we are saying here that this is one thing I'm sure you know very well, that for every time that you're really going to touch the patient, you need to have a proper hand washing so that you don't transfer your infection actually to the patient in that case. And also before you do a procedure, whether it is a aseptic procedure, whether it's just a clean procedure, you need to do a proper hand washing. Again, this is to protect the patient. And then after any exposure with the body fluids of the patient, even if it is urine, you need to have a proper hand washing. And this is now to protect you from any infection that from the patient. And then after touching the patient or the patient environment, as you leave the patient, you need to make sure you do a proper hand washing. So these are the 5 key moments of hand washing. And we are seeing that during this time of Ebola, we are following the guidelines of the WHO, which states that actually at the time of Ebola at this moment, hand washing with plenty of water and soap is the most effective way to remove the Ebola virus, should it be in your hands. So that's what we prefer now. And if that is not available, which shouldn't be the case, then we are going to use a alcohol-based hand wrap to do effective hand hygiene, using, of course, the guidelines of the hand hygiene. I know the picture of the hand hygiene has been put in across your facilities. However, it is when these two options are not there, that is when we bring in the jig, 0.05% solution, where you can be able to wash with it. Recurrent use of jig solution over time can crack your skin, and we are saying that the virus spreads through the mucosa and also through the break in the skin. So if your hands are broken, I mean, there's a small wound somewhere because you've been using jig for long, that's now that's the port for the entry of the virus. So we do not prefer the use of jig. We prefer hand washing with soap and plenty of water. And respiratory hygiene, we don't think that a case of Ebola one can get Ebola through as an aerosols or through the air in this case. However, theoretically, one might say, okay, you can have some droplets coming up, maybe if you're suctioning the patient or doing a certain procedure, but these are theoretical. The actual thing is through contacts, as we discussed. So for that matter, therefore, you typically just need to put on your face mask, but we know that this is a very minimal chance. But the most important thing in respiratory hygiene is to see that you open your windows in your facilities, and in your planning, you have a spacious facility, and of course, all your patients need to be taught on the cough hygiene, so that they can adequately be able to cough and safely discard the tissue that they use for coughing, or they cough on the folded arm. So in that case, therefore, we are saying that for respiratory hygiene, you have to catch up this germ from the source. So the person who is actually coughing is the one to be taught, and probably a mask is given to the person so that they can be able to use the mask if they are coughing. And in case they have cough, they can use the tissue, and this tissue should be binned appropriately because we know that infections can last in those tissues. And hand washing after that coffee, after that event should be done, because we know the hand can be the source of transfer of this virus. So then let's discuss the screening, isolation, and temporary holding, and then how we can notify the KCCA in this case. Yes, at your facility, we really want to see that all the people presenting to your facility have been screened properly using the standard case definition. That means that you are using the screening algorithm. And in that case, anyone who is identified should therefore be sent to a holding area. Again, there has been a definition. We have been redefining what a holding area should be, and what a holding unit should be, and what an isolation unit should be. I know you don't have the isolation unit. I know having a holding unit also is difficult, but in your small facility of 2 doors or two rooms, there should be a place where if a patient has met the case definition of Ebola, you can get a chair and sit that patient there, or you lie the patient just on a certain corner, and as you signal the KCCA. So we had been, this was not something which was agreed earlier, but we realized that small facilities cannot have what we want to be as a holding unit. So the definition of a holding area has just come on board of recent, but I know it will be reflected on the ODK, so that smaller facilities can have what we call a holding area, and that can be able to score that facility fairly well, because they can be able to identify, isolate that patient there, and then notify KCCA. So this is the minimum capability for all the facilities that they should have. For a higher level, of course, we want a holding unit, which unit should have a laminar flow. Staffs are